The broadcast is now starting. All attendees are in listen-only mode.
Good morning or afternoon to everyone. I'm delighted to have you all on the call. We appreciate it, and we look forward to speaking to you. The topic today is specialty medications, and the genesis for this has to deal with the questions that we've been receiving from our clients, as well as from non-affiliated individuals with regard to specialty. So we decided to try and answer a whole lot of questions all at one time and do this as a webinar. This is purely for education. I have no other particular agenda. This conversation, however, will be part of what we do to address what we've learned with regard to specialty over the years, what we've learned with regard to analysis. I'm Craig Stern, and we are consultants as well as analysts. I'm going to show you information, but at least let me put a stake in the ground, and that is we are analysts and have been dealing with integrated medical and pharmacy data for a very long time, probably over 20 years. Specialty is clearly one of those issues that is of current interest, and we are going to show you some information and some data, and I'll show you the positives and negatives of that so that you can evaluate for yourself about what it is. But I want to bring this into context for those of you who have asked questions about what is specialty, how do we deal with specialty, how do we deal with issues with regard to management and utilization, not just cost management, because at the end of the day, a medication that costs $84,000, $85,000 for even 12 weeks of therapy, as is currently the vogue with regard to the hepatitis C drugs, is a continuing issue and one that people bring up with regard to cost. And yet, even if you have cost control and can decrease the cost 10, 15, maybe even 20%, you still have a very expensive drug. And so the problem is, what else do you do about it, and how do you handle it? And we're going to address those issues as we speak. I'm going to try and deal with this whole issue now at one time, and the outline of what we'll talk about will be to deal with a definition. What are these specialty drugs? What do we deal with regard to medical and pharmacy coding, meaning how do you put the definition into context with a bill and what was actually given? How do you manage, how do you measure it, and what are the metrics? And then what are the management approaches, and what do you do besides cost management in order to address it, as well as what are the outcomes here? What can you expect that is going to be an actual impact of what you see? And then, of course, what's going to happen to the industry as a whole. Let me start with the fundamental problem, and that is many people have said that the problem with specialty is that there's no definition. I believe that the problem is there's too many definitions. Effectively, the question is, what are you talking about? There are very broad definitions like Medicare Part B that covers a significant amount of the injectables, whether it is injectables that is self-injectable that the patient can deal with at home, or whether it's an infusion that requires special infusion equipment that you get in infusion care or a hospital. At the same time, Medicare Part B does cover other medications, such as HIV/AIDS medications, diagnostics, enteral feeding, or those kind of insure-type products that people either drink directly or they put through a tube down their mouth. At the same time, there's the issue of self-injectable drugs, or those injections that someone would give at home, usually coming through pharmacy. There's provider-administered drugs that usually come through medical that are given either by a nurse or by a doctor. And then there's, of course, facility-administered drugs that are there. And others have used different cost thresholds. They've dealt with medication costs greater than $500, greater than $600. The number seems to keep wandering up. But bottom line is that it's an expensive drug. You're dealing with the difference between a small molecule, the common kind of medication that you pick up in tablets or capsules, that in general has an average cost of somewhere around $135 for a brand for a 30-day supply, versus medications here that cost somewhere upwards of $1,500 a dose or more. At the same time, there are other categories of drugs that are sometimes included in this depending on what people look at. And if you look at the entire cost of care, then you would be looking at administrative fees, potentially disposable medical equipment, radio-labeled medications used for testing of kidneys and livers, lungs, etc. Frequently diagnostic, but sometimes to review whether therapy has improved the situation or not. And also, when you're dealing with overall cost of care, you're dealing with all of the elements of the cost that had to deal with anti-nauseant drugs for nausea and vomiting, drugs for allergies in order to treat those, drugs to deal with inflammation to cut down on the side effects of certain medications. What we should never lose sight of is that these medications are very toxic. They are frequently not tolerated well or require other therapies in order to address them. And as a result of that, compliance is an issue, and we'll talk about that. But there are other issues that are just as important with regard to tolerating these medications, etc. So the question is, who gives them? Well, effectively, there are two major channels: the medical channel with all of the sub-channels, meaning whether medications are given in the physician's office, in the surgery center, in infusion centers, or hospital or otherwise. And just as an example, a cancer chemotherapy agent could be given in a physician's office. It could be given in an infusion center, emergency medicine, the hospital, or other. These are all very competitive sub-channels, and there's a significant amount of information that flows between them as to what has happened. Coordination of care is always an issue. On pharmacy, there are pharmacy sub-channels. The major part of this are the specialty pharmacies. Some of them are captive from a PBM, meaning they're owned by PBMs, and some of them are independent. Others are owned by health plans, but PBMs are certainly involved, pharmacy benefit managers, as is the retail pharmacy network. This whole sub-channel issue is complicated today because of issues of distribution restrictions of drugs from manufacturers to distributors or wholesalers to the pharmacies. But more and more, the retail network seems to be trying to get into that process and exert some sort of influence, although currently specialty pharmacy seems to hold sway. The question then is, if we know what these are, then how do we address the definition to what is actually administered? And that's where the rubber hits the road. There are different formats of coding, which leads to certain complications, but those complications are also being addressed by public entities now in order to try and get some kind of commonality. And that is, in pharmacy coding, you get a prescription. The prescription has a drug, a strength, a quantity, a day's supply. It certainly has a prescriber. The location of service is usually ambulatory, meaning it's at home or some other ambulatory center where people are walking in and out. And there is fundamental information that is included. One of those is, of course, the National Drug Code, the NDC, which is a defining characteristic for the drug, the package, the manufacturer, etc. There are certainly quantities that are identified, day supply, and then information about who was the prescriber, and location of service, as I say, has to deal with ambulatory. On the other side, on the medical side, we're dealing with all of those different sites where medication could be delivered, and the medication comes through a master book. It's called a HCPCS book, HCPCS. The drugs are frequently under a J code, but may also be on other codes. And it is based on not the package or the quantity that was dispensed, but rather something of a dose or a fraction of a dose for what was actually administered. There's frequently a date range problem in that there's one date and it doesn't show the entire date, and so you have a difference in the day's supply. The prescriber ID used to be more frequently the tax ID, now is the NPI number or the national provider number. And the location of service, as I've indicated, can have multiple subchannels, so the location of service depends on where it was administered. As a consequence, these codes, these J codes, represent a drug and a particular unit strength as defined, but there could be, for one J code, many NDCs, and for any given NDC or drug, there could be many J codes. So as a result of that, we have a many-to-many relationship. Date of service is frequently a problem, and the major problem today has to deal with quantity. There are rules for how do you code and how do you bill in order to define what drug you used and what strength and what dose you used, but many of those rules are ignored, and they have been for a long time. So as a result of that, Medicare and Medicaid have both exerted requirements that NDC numbers have to be on all claims so they won't be paid for, and the quantity issue also, while it's being a benefit and a major benefit of the pharmacy subchannels today, is something that won't last for more than a couple of years as Medicare and Medicaid get more and more into the process. The whole code, just as a background piece of information quickly, has to deal with the fact that there are really two sources of medical codes. One of them are the CPT codes, or the procedure codes. The author for that is CMS, or the Centers for Medicare and Medicaid Services. They cover issues such as DME, or disposable medical equipment, ambulance, drug, dental, etc., and have to deal with codes with regard to providers. There's also quality codes as well as modifiers to identify not just the procedure that was done, but particular elements of the procedure. On the other side are the HCPCS codes that I was just speaking about. The author of that is the American Medical Association, or the AMA, and this has to deal with drugs and supplies. And under that, drugs can be under A codes, B codes, C codes, G codes, Q codes, J codes, S codes, etc. All of those with a particular indication. G codes being mostly for the outpatient parts of hospitals, but can be for other areas as well. Well, just to bring this together, the required coding on the medical side is administrative code, so you have to have that J code or CPT code. You have to have a location of service. You have to know what the medication, the strength, the duration of service is. The service code, if it's a particular code that's used in facilities, a provider code for the doctor, and then a revenue code that's used in hospitals in order to group things, hospital supplies, etc. And it happens, you can see the different kind of metrics that are used. There are multiple bill consideration reviews that are done. Very commonly and more often than not in the current setting, there are some important bill consideration reviews that are done by claim examiners and health plans, physician groups, etc. And just as a quick summary, the kind of things that they're looking at are, does the quantity that was supplied in the bill, meaning how much was actually given, does it match the quantity that they approved for it on a prior authorization or pre-certification? What was the data sources, the HCPCS units, how many units of that was given, and what was the package unit? They're looking to see whether the submitted quantity is greater than the vial or package size. Are they paying for more than one package? They're looking to see if the submitted price is greater than the entire package price, trying to give a benchmark to what actually is being given. And these all have to deal with the quantity problem under the medical that we'll talk a bit more about in a few minutes. There are rules for pending claims. Pending claims means that the claim is going to be, it is not going to be paid, but it requires further information. And so they can be appended for requiring a J code that may or may not be there, an NDC code, drug name, strength, or quantity. And then finally, they have a particular emphasis on miscellaneous codes, which are kind of dump codes or not otherwise classified knock codes. These are some examples of them. These kind of codes are important in that, depending on the group, they represent somewhere around 20% of the total bills, which means that frequently you don't know what drug was administered, and so more and more there's the requirement for the rules for pending claims, as we've talked about, that requires all of this information. Now, there are some drugs that do not have a J code, and so they naturally do have a miscellaneous code of 3490, but at the same time, this is also a significant area where there is certainly waste and abuse, potentially fraud, as well as areas that require further definition because payment cannot be clarified because the information is not complete. And finally is the whole issue of pricing options. Whether it's in pharmacy or in medical, there are several different standards for payment. AWP, or average wholesale price, has been the standard for years. It is giving way to the wholesale acquisition cost as a standard for payment. And just as a general rule of thumb, and frequently not relevant, is that the manufacturer cost plus 20% is the WAC, WAC plus 20% is the AWP, and AWP plus 20% is what is paid by the purchaser. That has multiple variances, but is often used as a rule of thumb. Well, this was the AWP was frequently unknown to the purchaser. The WAC was frequently unknown to the purchaser, and it was well known that the AWP was frequently inflated by manufacturers in order to try and have their product more favorable or have a greater incentive to purchasers like pharmacies. However, this information is no longer a secret. There are national numbers now that are published. They're on the web. There's at least 6 states that have actual acquisition costs published to give as a benchmark for pricing, and sometimes the states are using that as the benchmark. The federal government has NADAC, or the National Acquisition Cost, that they're using. That is also published. There's at least a dozen states or more that are using a NADAC, and certainly more that have expressed interest in coming on for that. ASP is used for Medicare, and then there's at least 33 states that have published specialty MAC lists included in their overall maximum allowable cost pricing for generic drugs, but they've also published as part of or separate a specialty maximum allowable cost that they will allow for specialty medications. So the bottom line is that transparency issues are being blown away. The information that was known to the provider and not known to the purchaser is moving away, and there's multiple states now, public information, web information that's available to tell everybody what the cost is. Well, okay, so we know what a specialty drug is, or at least the different definitions that can be used. We know where and who is administering them, and we know what kind of issues are involved with the definition of them that is provided on the bill, which tells how much of the drug was administered. Certainly EMRs are going to add to that information, although currently the information is not terribly granular and it's not well. So as a result of that, we look to further information and metrics. So we ask a question about metrics. Now I'm going to show you some information. It's from Pharma information, and I want to address it because I want to talk about the different metrics that are used. But there are multiple questions that should be asked of me, of this information. They should be asked of any information that's given. And the most important thing is, was it vetted? Is this information information that is generally available and that can be used and that people can refer to? Well, the first thing is, pardon me. The first thing is that the information I'm going to show is from is from a private entity in the large market self-insured population. I've done that because I want to keep some continuity, and I've kept away from all of our data with regard to health plans and public plans because I wanted to make sure that we didn't have as much influence over benefit issues and other plan considerations. The first one is that commonly what's published in the literature, and to be aware, pardon me, there are not a lot of good data with regard to what costs and utilization numbers are, but in this, usually it's on a per member per year, read member as beneficiary. So the cost for every beneficiary per year, and in this regard, it's an index, so it can be compared across different vectors. The question you should be asking me right away is, what is the population this is from? What is the subpopulation with regard to size, benefit plan, issues with regard to what are the bases of costs, etc. And that should be asked of every one that deals with this. In this particular regard, these are AWP basis. They're from a large plan, non-public, meaning not Medicare, not Medicaid, and have to deal with issues that you see. Well, per member per year is an interesting piece of information. The problem is that it doesn't help you very much with regard to management, but it gives you some sort of an idea of overall what it costs in order to treat any particular beneficiary based on specialty. And remember, what you want to know is, well, what was included in this? And what I'm showing here, what was included is effectively everything under the Medicare Part B definition, so that I'm not trying to distinguish whether it's purely one drug or another, although obviously specialty has the major part of this because these were specialty analyses. Another indicator for this, aside from the per member per year or per beneficiary per year, is the total amount paid, to give an idea of where's the money going. At the same time, how much is paid per claim, and there are elements to this that I'm going to go into more specifically. But more importantly is the paid per utilizer per month. In this particular regard, these are the people that actually receive the medication. This is what can actually be compared frequently across different plans or benefits, et cetera, to try and benchmark as to what's going on. And finally, a per member per month type of issue that is done where you have a beneficiary that pays a premium on a per member per month, and then costs that are dedicated on a per member per month basis, so you can see what overall costs are. Well, the other question is, where's the money going? And on the pharmacy side, as I've indicated, specialty pharmacy has the by far greatest amount of it in the current marketplace over the network pharmacies, meaning the pharmacies you would walk into on a regular basis or available on a corner. But on the medical side, it's a bit different. Pardon me. On the medical side, as I've indicated, people can get these specialty medications in multiple sites, and costs are different. Inpatient versus outpatient, and as you can see, the majority of costs goes on in outpatient, physician office visits, and home, while there is still cost that's going on in emergency room and urgent care, et cetera. They have the majority. Well, this is a general idea of how much you're paying. On a per member per month basis or per that beneficiary, it allows you to do a comparison, and this gives an idea of what the costs are with regard to outpatient at about $13, physician office visit somewhere around $8, and home at about $2. Well, the other part of this, and a question that should also be asked is, well, what diagnoses are you paying for? Commonly today, the general discussion is around hepatitis B. And if you take a look at this, you'll see that on a paid per claim basis, in fact, more of the chronic diseases are where most of the activity is and where most of the costs are, with regard to kidney disease, pulmonary or lung disease, metabolic diseases, MS or multiple sclerosis, etc. If you look at it on a per member per month so that you can compare it across different entities, and clearly, as I've indicated, that you compare public versus private, and then with regard to plans, et cetera, you see that a good deal of the cost is being tied up in administrative fees, where the patient goes to the doctor evaluates, and then gives some therapy, and in that, the physician is coding an administrative fee, but the drugs, the specialty drugs as well, are all being given under administrative code that does not necessarily relate to a diagnosis. So you have a general code that's being given for all the procedures and drugs, et cetera, not necessarily for the disease. Now, people have asked me, well, what about hepatitis C? And the answer is that Hep C is important. Clearly, it's a major flag with regard to cost. But note that over time, and it's continued, is that the majority of costs today and going forward are going to be paid in the chronic diseases that are being treated month after month after month. The paradigm has changed. 10 years ago, specialty medications were for very rare orphan diseases that had very few people that could use it. They have now moved into the mainstream and are being used for chronic therapy. They're being used for cancer, for blood-related problems, rheumatoid arthritis, et cetera. And there are more and more drugs that are coming up for lung diseases like cystic fibrosis, et cetera. Well, when you deal with that, you're dealing with chronic diseases that are going to have long-term, long tails. They go on forever. And effectively, then, the specialty becomes the new brand. Biosimilars become the new generic, and these drugs then begin to replace small molecules in order to deal with treatment. Well, on a cost issue, because everybody's interested in cost, how do we compare that? And if you take a look at what goes on with package pricing for what is administered, once again, these are specialty. They're in a general environment so that we can compare medical and pharmacy. And in this particular group, the selection had a common member indicator. It was sterilized, but it was common, so you could compare pharmacy and medical to see what was going on. You can see the differences between package prices. You can see the differences in unit prices. And then this is, once again, the Medicare price also as a benchmark to get an idea for where the comparison is in the different units for that. Now, if you look at it on the medical channel, you have a much greater disparity, and you can see that there is, on one level, differences between urgent care, outpatient, and home, as we saw before, but you also see that there are differences with regard to units and packages, et cetera. Now, the problem still exists for the quantity that is administered, and the quantity that is in a prescription on the pharmacy side is pretty clear. It's one package, two packages, or a total quantity, whatever that is. On the medical side, we have this problem, as I've indicated, where billers, in fact, ignored the fundamental rule, so it wasn't quite clear how many packages they were giving. In the medical side, the J-code unit is the unit of ones, so whether it's in milligrams or milliliters for liquids, or whether it's in one for a whole package or otherwise, it can be different, but the HCPCS or J-code unit defines one. So as a proxy, what we have been doing, just as an example, is also identifying the number of packages paid, so we had some idea of what was going on with quantity. As I've indicated, this is a real problem today, but because Medicare and Medi-Cal have made it a major issue with regard to people following the rules and requiring fundamental rules for NDCs and quantities going forward, this is a temporary rule, and while it's a marketing benefit on the pharmacy subchannels today, it will become less so over the next couple of years as everyone follows. Well, there's obviously different numbers of packages that are paid in pharmacy and specialty pharmacy, as you can see here, but there's also different packages numbered that you would see in the different subchannels. Home has more packages, not a surprise, but this is also an area that people have focused in on because there's a significant amount of waste. So you can see in general what the overall impact is of the quantity by looking at it this way. The other final way that I'll deal with, and then we'll get into some specifics, is that depending on where you are in the channels, there's also a different price that you pay, meaning the different discount. In brands and generics overall, maybe a 13%. It's probably in the marketplace closer to 17% for brand. Generics run either at the same as brand or some sort of a discount. In this group, about 27%. And there is a difference between pharmacy and the pharmacy subchannels, between pharmacy, the network pharmacies, the retail pharmacies, and specialty pharmacy, where specialty pharmacy is about a 2% deeper discount on brand, and maybe a 9% deeper discount on generic right now. That clearly has been a difference, and as the different marketplaces begin to square out, as they did with point of sale with regard to small molecules, this number will probably change. The medical, on the other hand, is significantly different. There's far greater discounts for all medical, and as you can see, there are greater discounts depending on where the medication was administered, including not a discount, but in this case, AWP plus 15% for inpatient hospital versus home. Now, this has occasioned many people to look and to say, well, where is the best place where I can get the best deal? So it's occasioned some discussion on pharmacy networks versus specialty pharmacy, and clearly on medical, and then clearly medical versus pharmacy network. This kind of description could have been done in ASP, average sales price for Medicare. It could have been done in NADAC for acquisition cost or otherwise. I chose to do it under AWP because that's a common contract issue today, and in a few years it'll be less so, and we'll be using other numbers as well as comparisons. What thing you should say to me is, well, how do you compare, Craig? And the answer should be to be able to have an AWP discount, an ASP discount, a NADAC discount, et cetera. So you've got some comparisons to see how all of these different contracts compare. And more we're seeing contracts where they are using another basis for the contract than AWP historically. Well, the question that we have to address then is what do people use with regard to management? So I'm going to talk about this. I'm going to talk about utilization. Then I'm going to give you some real-life examples of what is done so that you can see how all of this is applied. But the first issue has to deal with formularies. Now, formulary would not have been an issue before, several years ago, because there wasn't enough drugs in any category to be able to compare or to even have a formulary. If you only have one drug that treats a particular disease, there's no point in having a formulary. However, people began to look, as there were more and more drugs to treat MS and Hep C and everything else, as to could they throw the same kind of controls against this as they did with small molecules. And formularies were one of them. They tried to shift pricing with regard to tiered designs so that members would have to pay more with regard to particularly more expensive drugs. There was step therapy designs now in order to say, did you use the first term therapy that is well established, effectiveness is known, risk is known before you go to the specialty drug, and there'll be more of that going on. There'll be restrictions and therapeutic substitution. We're seeing that now with several of the PBMs that are exerting influence on manufacturers and identifying, they're starting with Hep C clearly, and it's all over the newspapers about it, but they're identifying and trying to show a benefit. This creates a certain amount of confusion among the marketplace because the question is one better than another? And that's part of the formulary decision-making process. And then, as I've indicated, there's going to be more mandatory substitution as we begin to use a similar kind of paradigm to specialty as the new brand, biosimilar is the new generic, and then we'll have a group of particular drugs and arguments about whether something is better or not. And then, of course, hybrids of all of this. Well, all of this has to deal with cost control, although step therapy is certainly an issue with regard to utilization. But the idea is to lower the cost of goods, and the formularies to do so. Perhaps rebates certainly have an impact from the manufacturers to try and lower that overall cost. and also whatever discounts that particular contracts receive. But the bottom line here is that an $80,000 drug with a 20% copay, the member is still paying $16,000 or more, and as a result of that, they're looking at a significant amount of money even for one course of therapy. Well, what this means then is that cost control is only one piece of the total equation. You have to manage several things at the same time. Cost is one of them, utilization is another, and as you deal with utilization, I want to make it clear we're dealing with how much do people use. Is it a one time a day, one time a week, one time every 2 week kind of medication? How is it being done and how is it being addressed? The cost management, the utilization management both go along in lockstep, as well as management for what do you do about new entrants into a particular category and how they're going to be handled with regard to clinical information that is established with regard to formularies. There's also issues with regard to whether people are complying and whether they take drug holidays or discontinue the medication. So there are contracts in order to try and deal with if the drug itself is so toxic or difficult to handle that people are not sticking with it. Well, what that leads to is overall network management, meaning who's doing the best job. Namely, is a particular hospital doing better than other hospitals? Is a particular physician doing better than other physicians? And then, of course, the other concern, and that is, are there people who are taking advantage of the system? Are they coding in order to improve their revenue, but effectively they're just taking advantage and getting more money for the same thing? They may be upcoding or trying to make something look worse than it actually is, or using some of these not or not otherwise classified effectively, the miscellaneous codes, to get more money out of it and to address it. That's definitely a waste. It's potentially abuse, and it may be fraud, and so as a result of that, that becomes of interest to everybody. Well, if you're going to manage utilization, there are tools for that. One of the tools is to deal with first fills so that you try and limit the amount of wastage and supply that builds up in the patient's home by limiting the first fill to find out, did the patient tolerate, could they handle it, did they have any allergic problems with it. There are quantity limits and high dosage limitations to try and do the same thing to limit it so that you limit the amount of wastage. There are some indications in using them only for particular specialists, so that only a kidney doctor deals with the kidney problems, only a nephrologist, a neurologist deals with neuro problems, etc. In some cases that's true, but as they become more and more chronic medications, more and more the specialist sees them, diagnoses, starts the treatment, but then hands it over to the primary care physician, and so as a result, there may not be the specialist involved in long-term for chronic therapy. Spreading the treatment over multiple years is still in discussion. That may just be avoiding the cost and trying to deal with cash flow kind of issues. There are others that are trying to deal with cost shifting by moving the cost from either pharmacy benefits to medical benefits, or under particular types of medical benefits, Part B or D, in coverage to deal with it. This is really just cost shifting and doesn't really change anything with regard to trend, nor with regard to what's paid. It may shift a bit as to what a particular member pays, but more important, these kind of things are very variable and change over time, so we can't look at those as the long-term kind of solution. There's clinical management issues, and now genotyping is becoming more and more important, but what it means is before you can use a drug, you have to do a particular lab test, genotype test, to find out if the patient is going to be a good responder to the therapy. That is the front-loaded kind of problem, because once it's done, then the therapy is started. There may or may not be a need for it for continuing, but effectively you have a one-time fee that increases the cost of the total therapy. And then, of course, side effect profiling, which I'm going to show you some examples of in a few minutes. Finally is kind of a scatter approach where you kind of do everything without any particular goal in order to try and get to a result. Well, if we're going to deal with utilization testing, what I'm going to do here is I'm going to give you some real examples. Now, before I do so, I want to make it clear these are real examples, and ProPharma and I are directly involved in these on a daily basis, so I don't want to absolve ourselves from anything where someone is unhappy or find some concern about what the issues are. But I do want to make it clear, in utilization testing and pre-cert or pre-certification testing, this is done to comply with the benefit, not to make a decision about what someone has done, whether the patient is truly sick, whether they're going to get their medication or not. This is not a matter of trying to be the bad guy or otherwise. It's trying to deal with, one, ensuring that the right medication is given to the patient, two, that if a medication has been shown not to be terribly effective or useful, that there is consideration given to overall monitoring. Third is to try and prevent fraud, waste, and abuse. And fourth, is to try and make sure that the appropriate cost has been applied and not an inflated cost. I'll give you a few examples. Some of them are harsh, so for those of you who have weak ears, please pay attention to that or sign off. The first one is a diagnosis check. A specialty pharmacy submitted a claim for a 32-year-old female with a diagnosis code of 250, which is diabetes, and for a particular drug, tocilizumab, for 40 units for home administration. Well, diabetes at 250 is not a labeled indication for tocilizumab that's used for juvenile rheumatoid arthritis. So the drug would have been denied over the fact that the wrong diagnosis, wrong indication was given for the drug. Now, patient may have had multiple diagnoses. The problem is that this particular one wasn't there, and so the concern is this wasteful, is it fraudulent, but more importantly, it doesn't treat that particular indication, so resupply and give information as to whether there is an indication for this drug. Number two is the units. They gave 40 units. The J-code unit, and I did this because I wanted you to see, the J-code unit is 1 milligram, which means that 1 milligram is a unit of 1. So the bill included 40 units, and that 40 units meant that the quantity should have been 40 or 40 milligrams, but that in fact doesn't match to what the dose should be. So as a result of that, this particular claim was denied because of diagnosis, but could also have been denied because of units. Secondly, a quantity check. Another example, a specialty pharmacy, a different specialty pharmacy, submitted a claim for a 74-year-old female with a diagnosis code of 174 for a drug called granacitron, which is for nausea. The patient had two diagnoses. One was for breast cancer. A second one was for bone cancer, probably related to the breast cancer. And then granacitron for nausea. Unfortunately, the diagnosis for nausea is separate. It's for nausea, not for malignant neoplasm. And so it would have been denied because of this. But given the benefit of the doubt in that it could have been given for the therapy, then the question was the quantity, and the quantity of 30 units. Once again, in this regard, granacitron, the unit in the J-code is 100 micrograms. The quantity that was submitted was 30. The dose doesn't match to what the 30 units are, and so this claim was denied because of quantity for the granacitron. The third example, and I have literally thousands of these, but I've just picked a few just to give a point of what the issues are, is a regimen evaluation. An infusion center submitted a claim for a 21-year-old female with malignant neoplasm of the placenta. Sad case. The cocktail that was offered is not FDA approved, is not approved by the National Cancer Institute or NCCN, and so the regimen itself, not each individual drug, was denied because it wasn't a regimen for which there was data and approval for effectiveness and risk. There was also an issue with regard to, as we saw before, other drugs that were given, dexamethasone, granacitron, heparin flush, normal saline. All of this is considered specialty under these benefits. So I bring that up to you to show the breadth of what can happen with regard to a specialty medication review. And these would not have been approved because they didn't have the right diagnosis. But then there was also an issue with regard to quantity, and the quantities didn't match to what the doses should be. So the regimen, in fact, was denied because of that. And finally, I give you an example of a physician office that submitted a request for a 90-year-old female with a diagnosis code of 733, which is osteoporosis. And they gave a drug that would commonly be used for osteoporosis, denosumab. The plan had set up criteria based on evidence that they had put through their committees that there wasn't any evidence for benefit of this drug after age 78. So it was denied because of plan criteria, not because of diagnosis and the rest. This is what would come out of formulary and prior authorization criteria, and then quantity would have also been a problem because it's a 60 milligram issue. The quantity that was supplied is 1 or 1 milligram. It would have been given the benefit of the doubt that 1 was 1 vial, but it was still denied because of prior authorization. So now the question is, all right, are there any savings out of all of this? Doing all of this, is this just an exercise in futility? Are we really getting something that has some benefit? And let me just quickly identify the kind of things that can be found. I'm dealing with this in the same population, so you can see the same information as what I've shown you before. And once again, you should be asking questions about, okay, not only what is the return on investment of doing a program, but more importantly, what's the return on value? What kind of outcome do I expect, and what's there? The expected utilization, and what should you expect in any plan? And what kind of metrics should you use to define it? Well, basic questions are, what's the expected utilization versus the build? Is the dosage consistent with the diagnosis? The maximum minimum dosage, does it vary from the product label? And then are there benefit or formulary issues that would limit what goes on to address this? Well, here's some examples, real examples. Opportunity savings both by claim as well as by utilizer per month. And I would point out to you that this isn't an issue where one channel, meaning medical, is doing better than pharmacy. It's a matter where we have problems on both sides, so there's opportunities. You don't expect that everything is going to be perfect, but you do identify where the issues are because the numbers are not insignificant. Claims exceeding quantity limits just on a per claim basis are somewhere in the $3,000 range where there are savings on these $20, $30, $40, $50, $80,000 types of claims. Medical diagnoses frequently have the claim, pharmacy doesn't. More and more that's going to be overlapped, especially if you have the same patient number across pharmacy and medical, but there was a de minimis in this particular group. But the frequency, how often it was given, once a week, once every other week, et cetera, turns out to be somewhere in the $5,000 range where it's exceeding where the package labeling is. Zero quantities turned out in this group to be on medical costs. Invalid providers, this is critical because you need to make sure that, one, you have a valid doctor. Two is that you know what the specialty is so that you can compare that particular specialist with their peer group. And third is to ensure the fact that you're minimizing the influence of fraud, waste, and abuse. And then, of course, invalid or missing NDCs, as I've indicated, is a problem in medical, and the expectation is that this will effectively go away over the next couple of years. That is a common thing, but there's also clinical assessment, and I would direct your attention to the fact that drug interactions, whether it's just within the pharmacy data or whether it crosses pharmacy and medical data for the same person, is not insignificant. On a paid per utilizer basis, it's about $5,000. Specialty drug adherence, this is the compliance problem that has had a significant amount of focus. Drug holidays, people that are not complying for whatever reason, is about a $1,500 issue. But the main issue that has an even bigger impact that is rarely spoken about, but because these drugs are so heavily toxic and have so many problems, is the management of drug-induced disease and adverse effects, which swamps the numbers that we're looking at here at about a $37,000. These are all averages paid per utilizer. Once again, the questions you should ask me is what kind of population, what kind of disease, etc. And I've tried to limit it to the particular population I'm talking about so that you can get numbers. And while the individual actual number changes depending on the population, rates and differences between these continue. Well, if you look on the medical side, you have a similar problem. Drug interactions between the pharmacy and within the medical are worth about $2,000 in a particular utilizer every month. Drug adherence, about $2,000. And once again, drug-induced disease and adverse effects are still looking at about $12,000. Well, how do you know that it's a drug-induced disease and adverse event? And the answer is that one, it's coded in the claims. Two, is it allows you to see how different providers are managing this so that you can, once again, look at best-in-class and centers of excellence as to who is doing a better job. But you can also see it's not just a pharmacy problem or a medical problem, it's a problem that occurs in both. Well, what's going to happen in the future? Obviously, we don't have a crystal ball, but I think it's fairly certain that a few things are going to happen. One is there's going to be greater channel competition. Medical sub-channels are already very competitive. More and more in analyses that we do or others do are dealing with best-in-class to compare peer-to-peer or looking for centers of excellence for the best options for treatment of certain cancers or arthritis or MS or whatever. And clearly there's pricing competition, as we've talked about, and that is a non-trivial matter. Pharmacy sub-channels are going to be competing more with regard to access and service, which has always been competitive advantages within pharmacy networks, and price will begin to rationalize as it did in point-of-sale issues with regard to small molecules. But the larger issue is there's going to be more competition between medical sub-channels and pharmacy sub-channels. The medical sub-channels do not want to give this up. It's part of what they do. They have all of their teams in order to address it. Pharmacy sub-channels will certainly be competing over that business. And finally is the information supermarket, and that is we need to address and be aware that in the past we had kind of a problem where information was known on only one side, kind of a cognitive dissonance. In this particular regard, the information is now very open, it's very available. There will be issues on standardization of naming, so the biosimilars will be switched or part of the generic substitution. There will be metric standardization, more these questions that I've addressed with how people are using to address what metric you're going to use and trying to find some standardization so that you can compare. And the questions I've asked are important ones of every system, including these. And there's more standardization of language. In this regard, universal languages, so that one EMR, electronic medical record, can talk to another, hospital records can talk to ambulatory EMR records, and SNOMED for laboratory will be used in order to address it. And information, as I've indicated, pricing and quality, it's now public, so everybody can see it and deal with it. Well, I've talked to you about what we know and what we do with regard to ProPharma and our data analytics and what we know. So I bring it up to you for purposes. There's references here about it. And certainly if you have questions, we'll be happy to answer it. Do we have any questions? I see that there have been some that we've addressed. And one of the questions I see that has been asked is, what are the trends in pricing variation? Well, small molecules traditionally have been somewhere, at least in the past couple of years, have been somewhere in the 7 to 9%, now about 8%. That means that the doubling time, or the cost to double the cost of the small molecule benefit, will be in the range of 9 years. The trend in the specialty has been somewhere in the 17 to 18% range, and in certain categories like hepatitis B and others has been in the 30, 33% range, or hundreds of percent. their average doubling time is 2.5 years. So trends are different. Cost is huge, but as I've indicated, cost can only be one part of the management. Utilization has to be part of the other. There was also issues with regard to diagnoses, and the question is, are the diagnoses going to remain the same over time? And the general answer is, look to the chronic diseases to continue and treatment for the chronic diseases to continue, and there will be blips with regard to certain things like hepatitis B, etc., where there aren't as many patients to treat, but the cost becomes a major factor when you bring on new patient populations that have not been treated before or have been suboptimally treated, and so you have that blip. But over time, you're dealing with therapies that are for kidneys and lungs and heart and etc., neurological problems that are chronic diseases that people will use for the rest of their lives. Em, do we want to open this up to everyone to ask whatever questions they like?
Hi. If you would like to ask a question, you can raise your hand. There's a button to raise your hand, and I will unmute your phone so you can ask whatever question you'd like.
Any questions, concerns, or otherwise?
There are a couple more questions. Keiko has asked, pharmacy traditionally has not been paying rebates for specialty meds administered as medical benefits. How do you see that changing in the future?
Actually, there's two things. One is there have been rebates paid. The question is who collected it, and it wasn't necessarily public information. PBM certainly got rebates for them. Health plans got some rebates for them, and some hospitals and the rest certainly got cost relief or otherwise, whether it was through 340B pricing or otherwise. With regard to the rebates are now going to increase, and there'll be more visibility of those rebates as people are now aware and are asking for the rebates. So one can expect that there is going to be an increase. The benchmark is Medicare. Medicare has a maximum that has been specifically identified as how much can be paid in rebates. And so in general, people will look to that maximum as being the rebate amount that is the total maximum that could be paid. If they're in a different line of business or book of business, they may not get as much as the Medicare, obviously. But it'll give them a benchmark as to how much is going to be paid, and more of that will become well known because of the cost of these drugs. Other questions?
We have another question with regards to slide 18 about top 10 diagnoses by paid per claim and by PMPM. Do you feel the same diagnosis with the same proportions will exist 5 or 10 years from now?
Probably not in the same sequence, meaning maybe kidney won't be the top one, or pulmonary may move to number one, but I think you can find that the major organs will always be in the top category as chronic diseases. If they are one-time therapies that provide a real cure, then it will be a blip in the process, and there will be some increase in price, but it'll be short-lived. If it's a long-term, meaning chronic therapy for maintenance use, then they'll be used. And you can always consider there'll be more kidney, lung, neuromuscular, blood, cancer type of diseases that will continue to be the major indications over time. The one area is cardiology, and cardiology, the number one killer of all organ diseases, has not had a major impact in specialty as of yet. The major research in cardiology has had to deal with particular gene therapies, etc. But also, I would suspect, because there isn't a good inflammatory model for cardiovascular therapies at present. As that becomes to be fixed over the next couple of years, then cardiology will raise its head in this area, and you'll see a huge amount of cardiovascular drugs in this area. Other questions?
We have a question from Steve Miller. Can you give us your thoughts on whether or not all of the various ERMs will eventually speak the same language, and how long that will take to allow much easier gathering of all medical information, and will pharmacy information systems ever speak the same language as ERMs as well?
Yeah, that's a good question, Steve. There is a move to a standard language, as I indicated, the RX norm. In the very least, it's not a language, it's a dictionary, so that everybody is using the same terminology. And an NDC number will not be the common number. There'll be a more common language across all of the different entities, so that a particular drug, Enbrel or something, will have a particular dictionary name that will be common across all EMRs, hospital, ambulatory, etc. The issue that is of concern is that it is going to take a while. Hospital and ambulatory are leading the way on this, which is surprising because they've never led the way on any IT issues. They've effectively led the way or effectively been behind the curve for everybody else. But now they are leading the curve, and so over the next 5 years, the goal is for them to be more integrated. Pharmacy presumably will move into that because it's the most IT mature of all of the different specialties, but there isn't a huge move, nor has there been a lot of conversation in the pharmacy community to do that. So there's going to have to be more motivation, perhaps from NCPDP, perhaps from other regulatory or groups that have to deal with the standards in order to try and motivate and move that along. Eventually, that's the plan, and it is part of the Affordable Care Act to make that happen. So one way or another, that is the goal. I suspect that, as usual, it's going to take several years. It'll take at least 4 or 5 years to get the medical group online, and probably another 5 years in order to get everybody else moving. But it's already there. Dictionaries are already established.
We have a question from Ben. Do you feel that rebates are a viable option for manufacturers to provide to help offset the high cost of specialty medications to consumers?
Well, rebates like coupons, like discounts, earned discounts, etc., are a fact of life. They were a fact of life in the past. They'll be a fact of life in the future, and certainly manufacturers will provide rebates in order to try and give incentives for people to buy their drugs. I think the main thing here with specialty is that we have to understand that the paradigm has changed. We're dealing with a world where cost is not the only consideration in management. We're going to have to look at this as a multifactorial management. Part of it will be cost, part of it will be rebates in order to decrease the cost of goods that we're paying. Part of it is going to be utilization and clinical management. Part of it is going to be trend management. We're looking at multiple things that have to go on, and at the end of the day, if we kind of crystallize everything together, we're looking to see all of those issues that have to deal with producing a maximal therapeutic benefit at a minimum acceptable risk, because all of it has enormous risk, at an affordable cost. And we're going to have to manage all of that in those 3 categories together, and there's multiple elements of that. Rebates are certainly part of the story, but it's not going to help the person who has to pay $15,000, $20,000 a course of therapy and has multiple courses of therapy and effectively has to dig into savings and family and church and wherever else in order to try and come up with the money to cover that. I think we're out of time. I truly and humbly appreciate everybody for taking the time to talk to us. Hopefully this has been of benefit. If you have other topics that you'd like us to talk about, this is an educational session, as I've indicated. I don't have another agenda here. If you'd like something else, feel free to send us your ideas, and given that we deal with that a lot, we'll be happy to set up something and do another webinar. Having said that,